Professor Keiki Mehta, and he's going to be talking about newer techniques of enhancing accuracy of multifocal implants.
Can you see my slide, Namrita?
Yes, sir. Yes, sir.
Yes, sir.
I'm going to talk about a few newer techniques of enhancing accuracy.
Just have to make it slideshow.
Slideshow, sir.
Okay.
At the bottom right, or at the top, whatever.
That's a slideshow. Okay. Fine. Working?
No, sir.
No.
Is the cursor not moving, sir? On the top, first, second, third, fourth, fifth, sixth, seventh icon on the top.
1, 2, 3, 4, 5, 6, 7. Use slideshow. Okay, done. Fine.
Super,
Yes.
sir.
Let's hope everything is working. Good.
Yes, sir.
Excellent. Thank you. Well, one of the big problems we always have is refractive surprises. It was wonderful to have Damien give his talk before mine, because a lot of the talk which I'm going to do essentially is dependent on the work which he has done essentially. One of the easiest ways to improve patient outcome is to enhance the accuracy of the implant and the accuracy of its fitting. Once we do those two particular things, we can essentially improve the accuracy of what we want to do. So the first step essentially improve the biometry, fit IOLs properly, and most important of all, something we ignore all the time, improve the corneal surface. So first and most important, of course, is the two essential things we need to consider, which we somehow seem to leave out, is the role of what we call as telecentric keratometry. More accurate formula, fortunately Damien has spoken a little before me, and to enhance the accuracy of using posterior keratometry. I use a SwepSource Master, and I do feel that it works really well, because it has the advantage that when you are doing it, you can be sure that your OCT is being done accurately. The other big advantage, of course, is the role of telecentric keratometry. And as you will notice here, when the unit is taken closer or further away, it measures different zones of the cornea, which then will give you a problem. So you need something which will measure a constant zone size. Having done that, you need to have one of the advantages of using the IOL Master, and mind you, have nothing to do with size, is that you can do these measurements fairly accurately without having a problem. The newer formulas, of course, made a lot of difference. We have the Holiday 1, the AQ, which was the generation 2 formulas, and then we came on to high gaze and Holiday. And now most of us are on Barrett, which is working quite well, especially the Barrett 2K, which uses posterior K readings. The posterior corneal curvature, I think, is something which you always have to take into account. It is crucial. It has been the device choice for anterior and posterior curvature maps. And though the Barrett formula has a fudge factor, the newer formula, which is the Barrett 3, essentially gives you the ability to take your TK values or total keratometry values and apply them with more greater accuracy. And the advantage of TK essentially is it gives you a much more accurate results of your IOL calculations. The posterior corneal surface has a total impact and something you need to consider. Of course, the next most important thing is accuracy of placement. You can calculate an IOL with perfect accuracy, but if you can't place it accurately, all your effort is essentially wasted. And the most important thing is that you lose what we call as a wow factor, which is something which every patient wants and which every surgeon wants. So I tend to use a markerless guided system, and with heads-up display, which is fitted into the Zeiss system, which I use using a combination of the IOL Master, the Callisto, and the OPMI, you can manage to get a fairly accurate fitting running down the line. And essentially, we need to move down the line. And a thought-provoking concept which I would like you to remember is a proper placement of the lens. The effective lens position, something which Damien has also spoken about. The effective lens position is really important. A lot of the formulas don't take that into account, and you do have to consider when you're placing it. Do remember that once your capsule has broken its edge, your ELP position of your IOL is going to change, and you have to look into that at that particular stage. The size of the capsular excess also affects the ELP, and that is one of the reasons why I do feel that the use of flax for IOL placement is really makes a significant amount of difference, because you can place it exactly where you want to. The actual and predicted ELP is much more better utilizing flax system. When we switched over to flax, we had no problem with premium lenses, but we do felt that the better centering gives a difference. You have to do remember at this one particular stage is that though the size of the capsular excess remains identical, whether you do it by hand or do it with the flax, because the bag is not taken into consideration, the point remains that when your opening is perfect, later on when strictures take place, as it always does, the implant stays right in the middle rather than going off to one side. Those of us who are doing trifocals regularly over a period of 4 or 5 years, if you have not used a flax, you find that the implant is no longer perfectly centered, which tends to cut down the quality of vision. Ocular surface disorders, as I mentioned earlier, you do have to look into the condition. And as I turn on and always state, a drop of fluorescein will save you a great deal of anguish later on. So do check your positions out. Lubricating eye drops, make sure you get your cornea in a perfect condition, because the worst of the lot is at the end when you do and you get up and you're finished and you're not looked into this, the patient says that my vision is blurred and you wonder what has happened. Results, if you are careful and properly done, are quite gratifying. Uncorrected visual acuity in 3,500 cases, just a sample size essentially, shows that we can manage to get fairly accurate results running down the line. And this is the frequency of results post-op and pre-operative. And the change in best corrected visual acuity from pre-op measurements show that it is quite stable in all ways. Leaving aside the analysis, the fact remains that the reading vision is exceptional from day one, and the photic phenomena are comparatively less. But if you ask the patient symptoms, because at the end of the line, it's the patient who finally makes the decision, you will find that the symptoms are rated comparatively less, though night driving problems are there in the earlier stage. So we do have to inform the vision. Patients tend to settle down in about 3 months' time. So we do need to tell them that you may have a little glare and flare at night. Do remember to use a lubricating drop. I tell them to keep a lubricating drop bottle in the dashboard of their car. Most patients are very happy with trifocals, which is what I like to use. And the future developments hopefully will give a better result, especially as more and more better formulas come to giving us more accuracy. I just want to share a little couplet in the end that everybody wants happiness. Nobody wants pain, but you can't have a rainbow without a little rain. Thank you for your patient hearing.